biggest obstacle in evaluating falls in older adults is that people are reluctant to report that they've fallen. Um, there's, I think, often a disconnect between people identifying falls as a medical event, and so they don't commonly tell people if they've fallen unless there's been a significant injury. Similarly, medical providers often don't ask older adults about falls routinely, and in doing so, we miss an opportunity to intervene for people who've had falls but not yet had injuries from falls, because that initial intervention into falls allows us an opportunity to modify some of the risk factors that a person might have for falls, to provide a comprehensive assessment for factors that person might have that puts them at risk for falls, and to develop with the patient a care plan to really maximize their function and minimize the chances that they'll have a fall that could result in a significant injury. So I think one of the big things that we can do is engage in the conversation, really ask about falls, ask about balance issues so that we can intervene early.
Falls can affect the older adult in the long term on several different levels. The first of which is can result in a loss of their independence, especially if they were living alone or with another elderly family member that was their primary caregiver. If they have a loss of function such as a fracture or a stroke, it's likely that they won't be able to return home immediately, or if at all.
Older adults are very affected by falls. I think people commonly think of the injuries that people have from falls, and acutely that's a big effect of falls. But falls can also contribute to changes in activity level, so that people who have fallen are much more likely to restrict where they go and restrict what they do. This can contribute to development of frailty, lower muscle states, can also contribute to social isolation, which can impair the quality of life of an older adult. And falls can create a fear of falling, which in and of itself is identified to be a risk factor for more falls, and can in and of itself have a lot of psychosocial impacts on older adults.
I think it's important for EMS and fire departments to help reduce the number of falls that elderly people sustain by doing little things like when you bring them home or go pick them up, if you can, make sure that the throw rugs are not all over their house, or make sure lamp cords are away. If they have light bulbs that need to be changed, maybe change a light bulb so that they can see what they're doing. Another really big one is the nurses and doctors in the hospital frequently aren't seeing the environment they're coming from. So we have a unique advantage in seeing exactly what their environment's like, and I think we're in a unique position to make some recommendations in terms of if that situation is appropriate for them. So getting social services involved in some of these people's lives and getting them a more appropriate placement.
EMS is actually well suited to help older adults with their fall risk. I think one of the first things they can do is ask, engage in that conversation with an older adult about whether they've fallen recently, and if so, what the nature of the fall was. That starts a conversation that puts in both the medical providers but also the patient and their families' minds the importance of really discussing falls. The second thing that I think really is important for EMS providers is that they have an opportunity that most healthcare providers don't, to see where a person lives and how they live. And that glimpse into the environment can really provide wonderful opportunities to diminish fall risk. So seeing how the home is structured, how the thoroughfares in the home are, and whether they would contribute to difficulty ambulating in that environment. Looking to see if the lighting is maximized, if there are throw rugs on the floors, if there are railings places where railings or grab bars might aid an older adult in their balance. I think it's often often not given enough value that simple advice from well-respected providers like emergency medical service providers to look at those types of environmental issues, get rid of the throw rugs, consider putting up a grab bar, is actually well heeded by older adults, and may create an environment that's much safer for people. The other things that I think EMS providers see are things like footwear. I know from working in the hospital, by the time I get my patients, usually the shoes are off, so I don't have a sense of things that may seem small, but that certainly could contribute to falls, whether people are wearing appropriate shoes, whether there were shoes on at all when they fell. Again, small things, but things that really can contribute to the stability of an older adult. Medications, I think, people who are in the home have the opportunity to see the different pill bottles and polypharmacy that older adults are taking, and have an opportunity to both relay that to other medical providers, the primary care provider, the emergency department physician, but also start that conversation with families and patients about the risks of certain medications.